We welcome you all to the instruction course on mastering Pre Descemets Endothelial Keratoplasty. We have in the panel along with me, I am Dr. Lional. I am medical director with Dr. Agarwal Sai Hospitals, and in the panel with me is Dr. Sumadi representing Dr. Amar and Dr. Susan, and she is head of cornea services in Dr. Agarwal Sai Hospitals in Chennai, and Dr. Karpavalli, who is a cornea specialist and heading Dr. Agarwal Sai Hospitals in Salem. So as we know, endothelial keratoplasty is now becoming the procedure of choice in cases of endothelial dysfunction. So we are trying to take you into a new a surgical technique which we call it as Pre-Descemets Endothelial Keratoplasty, and which we practice. And we have got good presentations in line, and we'll also be having sufficient time for discussions.
Now I call upon Dr. Lional Raj, Medical Director, Regional Medical Director, Agarwal Eye Hospital, Tirunelveli, to talk about introduction to various endothelial keratoplasties and Pre-Descemets Endothelial Keratoplasty.
Good morning, one and all. These are my financial disclosures, and I do not have any financial interest in the following topic of regard. So it's an introduction to endothelial keratoplasty and an introduction to Pre-Descemets Endothelial Keratoplasty, a version of endothelial keratoplasty. As we all know, endothelial layer is the innermost layer of cornea, and which has got numerous cells of about 4,200 cells per square millimeter by birth, and over age the cells tend to decline. And we also know that endothelium has got an effective pump mechanism, sodium potassium ATPase associated pump mechanism, which always pushes fluid out of cornea to keep the cornea in relative dehydrated state. That's the reason for translucency of cornea. And we also know till date that endothelium has no propensity to regenerate. Once endothelial cells are lost, the neighboring endothelial cells swell up and take its position. That's what we know. In the adulthood, we tend to have nearly 2,800 cells per square millimeter, and whenever there is less than 800 cells per square millimeter, we tend to develop corneal edema. And on the other hand, we also know the evolution of corneal transplantation, which was first documented successfully by Edward Sim. To him, all the corneal surgeons we pay tribute. And after that, there were several series of evolution of keratoplasty, several modification of techniques following penetrating keratoplasties. And the most which I wanted to deal in the present day scenario is, one is DSEK, the Descemet stripping endothelial keratoplasty, automated or ultra thin DSEK, the DMEK, Descemet's membrane endothelial keratoplasty, and the newer technique which we want to postulate, the PDEK, Pre Descemets Endothelial Keratoplasty. The principles of corneal surgeries for endothelial diseases include, one is penetrating keratoplasty, wherein, as we know, we replace the entire thickness of cornea. The second one is DSEK, where we remove we strip out the Descemet's membrane and the endothelium complex, whereas we add a portion of posterior stroma, Descemet's membrane, along with endothelium. And the DMEK, wherein we just supply the patient with endothelium and its Descemet's membrane. So endothelial keratoplasty has gradually replaced penetrating keratoplasties in non-scarred endothelial dysfunction syndromes, and has become the main method of treatment for various dysfunctions of endothelium. Why? Because EK is safe and effective and can also achieve good postoperative results along with limited risk for rejections. The surgical techniques and postoperative effects have been improved continuously along with the development of microsurgical technology like femtosecond lasers and surgical instruments as well. The present endothelial keratoplasty practices, what is being followed universally is one is DMEK, Descemet's membrane endothelial keratoplasty, the DSEK and its version of ultra thin DSEK. Ultra thin DSEK is a hybrid of endothelial keratoplasty which is safer than DMEK but has similar visual outcomes. I'll tell you why. And visual recovery after ultra thin DSEK is almost similar to that of DMEK. In ultra thin DSEK there is some amount of stroma which also gives support to the endothelium and Descemet's membrane, whereas that lacks in DMEK. So the procedure becomes tough. And the new procedure what we wanted to tell you now, the PDEK has the properties of DSEK but can be done like DMEK with excellent outcomes. So comparing DMEK or PDEK and DSEK, this though it is a older procedure, the ultra thin version is a newer one. Level of difficulty is less, easier learning curve, but it is tough. DMEK is tough. Type of procedure is tissue additive. Yes, because of addition of layer of stroma, there will be induced hyperopia in DSEK, which is not found in DMEK or PDEK. There is a requirement for anterior chamber, artificial anterior chamber. There is a requirement for a microkeratome or femtosecond laser. There is a requirement for special injectors and glides. So expensive equipments, increase in corneal thickness, and endothelial cell loss is supposed to be more with mechanical separation of the Descemet's layer and the endothelium in DMEK. But PDEK has a property of ease of learning as that of DSEK with endothelial protection like DSEK. The possibility of graft rejection is there in both the sequences, however lesser with thinner graft, and other things are not much significant. So here I go with the femto assisted laser endothelial keratoplasty just to show. I make a thin, ultra thin layer of dissection in the posterior stroma, somewhere around 50 microns, along with endothelium and Descemet's membrane. But remember, such procedure requires advanced instrumentation which cannot be performed in all centers. Once the dissection is done, I mark the stromal surface for the orientation of the graft. Separate the tissue. Do a cataract surgery along with a routine Descemet stripping of the recipient cornea. Load it in a special device like a Busin glide. Get it into the eye of the recipient and attach by means of air after proper centration of the graft. This is an ultra thin DSEK which cannot be performed in all centers and needs sophisticated instrumentation. This is how the case look like. You can see a thin, very thin, ultra thin layer of stroma with corneal endothelium and the OCT. This is a case of DMEK where I do a mechanical separation of the layer of Descemet's with endothelium. Has a very long learning curve, and even in experienced hands, getting a successful graft is a challenge. but it doesn't require an artificial anterior chamber. It doesn't require sophisticated equipments. Once a successful separation is made, use a special injector or even a Medicel injector, which I follow, Medicel MA60 injector, and get it into the patient's eye. And this is in a DMEK in a post-grafted eye with failure, endothelial dysfunction failure, and you can see the attachment of the graft clinically and by OCT. So with this, we introduce a newer technique which has the properties of having some amount of adequate tissue like an ultra thin DSEK, but however very easier and less sophisticated instruments we require, that is the Pre Descemets Endothelial Keratoplasty. I got eminent person Sumati to talk on it, talk on step by step how a PDEK graft could be made. So PDEK is the latest iteration in the arena of endothelial keratoplasty procedures. It encompasses the involvement of pre-Descemets layer, which gives sufficient strength along with Descemets membrane and endothelial complex in the donor graft lenticule. The addition of pre-Descemets layer to the donor graft facilitates better and smooth unrolling of the graft in the recipient eye as compared to DMEK graft. Also, PDEK entails the inclusion of the pre-Descemets layer in the donor graft, thereby providing the benefits of DMEK like speedy visual recovery and overcoming the disadvantages posed by DMEK. PDEK take ultra thin DSEK to a thinner level whilst retaining its advantages but not requiring sophisticated instruments, as I had told already. Moreover, the pre-Descemets bubble can easily be created in young corneas. That is a major advantage over Descemets membrane endothelial keratoplasty. These are eyes with relatively higher count of endothelial cells, and therefore it enables a successful endothelial transplantation. This is a short video of how a pre-Descemets separation is done. A 26 gauge needle directed towards the center of the cornea creates a separation of the pre-Descemets layer, pneumatic separation, not a mechanical separation. I enter into the pre-Descemets space, open up the graft, take a graft. After a conventional microphacoemulsification surgery, I load the graft into a Medicel MA60 injector, do stripping of the Descemets membrane of the recipient cornea, and inject the graft. Here in this case, I had removed the epithelium for visualization. I used endo eliminator for effective visualization and anchored the graft with an air tamponade. So with this introduction to endothelial keratoplasties, the recent day practices, and introduction to pre-Descemets endothelial keratoplasty, I now request my co-chair, Dr. Sumati, to talk on stepwise manner of how to harvest a PDEK graft and tips for successful PDEK surgery.